Okay. All right. So I'm sure that you have done many patients. You look after many patients with oxygen therapy, some sort of oxygen therapy. But as I just wanted to mention everything, maybe it's a familiar topic for you, but I just wanted to brush up your memories. I'm sure that's something you can take from this class because we are doing this oxygen therapy every day. But the important thing I just want you to take from today's lesson is oxygen is a medicine. So all of us know that oxygen is a medicine, so it need to be given as a medication. So it need to be given as a correct dose. If it is not required, don't give it because we don't treat the patient with oxygen if they are having breathlessness. If they are desaturating or their oxygen level is low, only we give oxygen. Otherwise, just they can breathe in room air and they can survive. During my ICU experience, what I have noticed that many patients are intubated with 21% of oxygen. So they are getting FAO of 21%, but they are intubated. They got endotracheal tube. What could be the reason for that? They don't need oxygen support, but what they need, their accessory vessels are not working enough. Their breathing is not good, so we are supporting the patient with some air. We are pushing the air and inflating the lungs. That's all they are getting. So why I was telling that intubation, mechanical ventilation, or ventilator, when we hear about those things, we always think that patient needs some oxygen. No, it's not always the case. Why I'm telling this? Oxygen is a medicine, so whenever we need, we give. Otherwise, we don't give. So we will just go through all these things. But if I'm explaining too much, you can tell. This oxygen therapy is it's a familiar topic, but I thought maybe we'll just go through all these things. And I'm a bit worried whether is it recording or no, that's fine. I can come in and out.
You're not in it.
No, that's it. I can come in and out. But my voice they can hear. That's all right. Oxygen is widely available, commonly prescribed that when administered correctly can be life-saving. That is the thing. So as I mentioned, this session we will be looking at many things, including humidification and patient positioning. As physiotherapist, I am very glad that when I'm getting a patient in ICU with a lot of chest flame and X-rays bad, when I see the physiotherapist, I'm so glad because you know the technique how to recruit the lungs, isn't it? You do some bit of physiotherapy. Then after the physiotherapy positioning, we can see the difference. The patient's saturation is coming up very significantly. That means physiotherapy has got a very, very good part in improving the patient's lung condition. So that comes here, maybe positioning plus physiotherapy technique. So I don't go through that because you are experts in that area. Oxygen. Need oxygen for energy production to it convert glucose, protein and lipids into energy. If no oxygen in the tissue, they will develop necrosis. As you know that if you put a tie on your hand somewhere, what happens? The oxygenated blood is not going there, it will start dying there. Okay? So same with the other people in ICU. As you know that patients are getting pressure injuries. Why they are getting pressure injuries? Because maybe I will focus students because these people may be knowing more things. So I can target you guys. So why they are getting pressure injuries? Because they are not getting enough circulation. That means the oxygenated blood is not going into their body. That's why it is that part is hypoxic, then it will die eventually. That is what happening in pressure injury. Same with other situation when you are looking at oxygen. If patient is not getting oxygen to the brain after the cardiac arrest 4 minutes, what will happen? Brain start dying. Okay, if the patient is not getting oxygen into the vital organs, what will happen after 4 or 5 minutes? It will die. So even though the CPR or cardiac compressions bring back the patient's life, but they won't be living in a normal life because they lost their brain, because it cannot survive without oxygen for more than 4 or 5 minutes. Oxygen therapy is treatment for hypoxemia, not for breathlessness. Aim is to achieve normal or near normal oxygen saturation for acutely ill patients. Oxygen should be prescribed to achieve a target saturation 94 to 98 for most acutely ill patients, or 88 to 92 for those who at the risk of hypercapnic respiratory failure. You know this. COPD patient, we don't need more than 88 to 92% of oxygen, because their baseline also is bit low. When I was talking about the 88, yesterday when I was at work, my wife called me and she said the third, I got 4 daughters. Third one having a bit of cough, chesty cough and flu and everything. Then she checked the saturation, because during the COVID, we were getting that saturation probe, isn't it? The portable. I got one because my wife was COVID positive. The Ministry of Health sent one saturation probe at home, so that is still there. So what she did the saturation checking yesterday for my third daughter, because she was having a bit of breathlessness. What was the saturation? She was telling, oh my God, it is 88% only. So she was a bit panicked. I said, no, she always get panicked. She was about to call it 000 because she knows saturation is too low. And I said, no, don't worry, just we got a nebulizer at home. So I asked her to give some nebulization, just a bit of physiotherapy. After that, it came up to 93. And in the evening when I went home, it was around 97. I don't check that because sometimes when they are having flu and all this chesty cough, sometimes it can be the low. For us also, if we are checking, maybe we are scared because we know it is low. So don't check saturation when you are having too much chesty cough. All right. Okay. Acute hypoxemia is considered dangerous to healthy subject with a PO2 of less than 60 with oxygen saturation around 80. So if the ABG showing PO2 below 0.6 or saturation 80, it is really bad. Yeah. You have an experience whether you have called a med call for desaturation. Anna? Yes? Yeah? Grace?
Yes.
Yes? Do any of you want to share any experience? What do you do when you see that low saturation?
Yeah, I guess it depends on what the cause of it is. Sometimes it might just be mobilization and then the patient just, when you come back, like we've taken them off oxygen and come back and recheck their stats, gone down to 80.
80.
Of course, if you're like, oh.
Yeah.
Then you probably just whack them back on oxygen, wait for a while, and if it doesn't come back up, then I might just increase it. Depends on if the patient's a retainer. If it's a retainer, then probably not. But if it's like normal, I'll jack it up a bit, wait for it, goes back to normal, then I'll just slim it back down. That's one scenario. Another scenario is when your patient's drowning in phlegm.
Yeah.
And then just defatting and defatting.
Yeah.
That can be.
Yeah. Because the other day I was in I was working as med coordinator. I gone to med calls, and when I was came down to ICU bed 8, she was fully dependent on CPAP with 80% of oxygen. she was a bit confused what she was trying to pull out things in between. So when I went there, patient was having saturation of 56, unconscious. Why? Because patient pulled out the mask and mask was in the side. The looking after nurse was not there. So it was 56, she was diagnosed. Then people, the nurse came that same time and he pressed the emergency button. But I said, okay, let's try this, put the mask and put it in the patient's face, 100%. Within 2-3 minutes, back to normal, started talking. So that if you are missing that moment, what will happen? What can happen? Patient can die maybe within 3-4 minutes. It was the right time. So it is very important when you are working in the ward, students who are receiving something. So just flag the person who is there. If it is needed, just do the intervention. That's all. Okay. So acute oxygen forms important medical treatment versus stage 4 mass hemorrhage, active convulsion, and hypothermia. This one fits. If you are seeing a patient, what is first intervention? Give them a good position, maybe left lateral or right lateral position. Then if the oxygen or if oxygen is available, give oxygen. And what you can do, if you have any oropharyngeal airway, you can put that to prevent tongue biting. Yeah. So what I wanted to say that oxygen is very important because when they are doing that activity, the brain is not getting enough oxygen, so we need to give some extra oxygen. If they start breathing, they can get some oxygen. And hypothermia, why we need oxygen in hypothermia? We need to give actively some oxygen for the patients with hypothermia. Why could be? What could be the reason?
Vasoconstriction.
Yes. Yeah. Yeah. Vasoconstriction, so the oxygen is not getting into the body everywhere. So we are trying to give some extra oxygen, and that will reach the patient's vital organs. Yeah. Resuscitation mean you know that for yes, you know that massive hemorrhage. Yeah. Do you know how why? Well, I can talk that later. It can be also used for post anesthesia. So the post-stroke patients are getting increased gas exchange become the nature of the illness. Yeah. So that things you benefit post-stroke patients. They can they may reduce nausea, vomiting, reduce risk of surgical wound infection. In ICU patients, impact of organ failure and reduce length of stay. So this is other thing. Oxygen, carbon dioxide, CO2 retention. So these are the signs and symptoms: central drowsiness, mild necrosis, dizziness, confusion, headache, and gorgeous. Mostly when we will notice at this stage only. Oops. I can't touch that, isn't it? So at this stage only we will notice that when they become unconscious. We get patients in ICU. They are CPAP or BiPAP dependent. When they get the patients, if their CO2 is very high, sometimes what we will do, we will just try the nasal probes. Okay, give them a break. After sometimes they will retain CO2, they become unresponsive, then we will check the blood gas, the CO2 may be 102, maybe 115, baseline. For those patients, maybe the baseline may be sitting around 60, 70, that's okay. But for us, what is normal CO2? Students can say.
Normal CO2?
Yeah. In the arterial blood gas.
38 to 42?
Yeah, somewhere there, 35 to 45. Yeah, that's very good. So visual, so their eyesight, auditory, they may be less hearing, sweating, all those things. Respiratory, shortness of breath, and muscle, they may have trauma, heart, increase heart rate and blood pressure. Yes? Those so if the patient is having CO2 retention. Yeah. Drying of the complications of oxygen therapy, drying of mucous membrane, pulmonary lactasis, thermal monitoring of saturation, decrease oxygen, node ventilation, oxygen toxicity. Who can say what is oxygen toxicity and what is signs and symptoms of that? Maybe again the next student. Yeah.
Symptoms. Could it be feeling drowsy with
Mhm.
oxygen?
Mm.
Could it just be the feeling vomit, like nausea as
Yes.
well?
Yeah. They are hearing this. Next slide is the signs and symptoms. They can compare that. That's good. Yeah.
Yeah. Maybe the oxygen therapy isn't working anymore, so the SAPs might be.
It's a toxicity, more oxygen. Yeah. Yeah. So okay. So those things you are right. So you just have a think of. So they will have. They can have seizure, visual field loss near cataract, bleeding, fibrosis, muscle twitching, jerky breathing, irritation of pain, shortness of breath, tracheobronchitis, acute respiratory distress syndrome, ARDS. Okay, so they can get all of these symptoms, but we don't want to get into this point, so always give the oxygen as a medicine. Visual impairments, nausea, yeah, you said that. Irritability, anxiety, mood change, confusion, exposure, tunnel vision, bringing in ear, nausea, dizziness, twitching, seizures. So I just wanted to say that before getting into this point, they will get this. Yeah. All right, so these things we can just quickly go through because I am sure that you are familiar with these things. So we have nasal cannulas. Nasal cannula is with the two prods. So we put it in the patient's nostril and connect it to the oxygen. So it's literature says that we can go up to 1 to 6 liters for this device, but ideally, if you go over 4 liters, it will be so much uncomfortable for the patient, and they can get bleeding. They can get they will get irritated because too much flow is going and the dry oxygen is going. If you're doing the high flow nasoprom, that's the story is different. But dry oxygen up to 4 liters is preferable. So if you are using the nasal prongs, you go up to 4 liters. Yeah. So what all the things you need to be mindful when you are doing that? You need to mindful. It is not too tight when you are putting that. You know how to put this? Yes. Yeah. Through the ear and just tie. If you tie too much, they will suffocate it. So just enough, and look at the back of the ear. There is no pressure injuries, and not more than 4 liters. Yeah. And next is simple face mask. Yeah. So just a Hudson mask. So as you have seen these things, I'm not opening this. You just connect this green tubings to oxygen cylinder or wall oxygen. Dial up to whatever you want, and there is a steel that you can pinch the nose and make it seal. Yeah, and it has got holes in the side. Do you want to open it or not? Students, these people are familiar with these things. Yeah. So when you're putting this, yeah, just pinch that so it will fix on the nose, and it has got a hole. Do you know why the holes are? No? There are two purposes. One is it is mixing with the air. So oxygen is mixing with the air and we are sucking in. Because if you are giving 6 liters, that's enough for the tidal volume. No, it's not enough for their tidal volume. What's the tidal volume you will need? You need 5 to 7 mL per kg body weight. If you are 100 kilogram patient, how much, what is the tank volume? 5 to 7. So 100 kilo, maybe 500 ml to 700 ml they need to get it. If you're giving 6 ml, it's not enough, isn't it? So they can suck the air through this. And what is second use? The CO2, carbon dioxide, water is accumulating, because when you're breathing and breathing out into the mask, that CO2 need to go out, isn't it? Otherwise they will breathe in again. So that's the two purposes of this. You connect this to the wall, and at least you should have what's the volume should be, I mean what's the liters per minute you should start with this mask. You should have at least 5 liters. Why? If it is less than 5 liters, if you are giving 2 liters for this one, what will happen? That's not enough to push the carbon dioxide water which is sitting inside. So you need to have at least 5 liters to push the carbon dioxide outside. Then only there is a good airflow happening. So that's the other thing you need to be mindful when you are doing the Hudson mask. Yeah. Then we got what is it? Yes, non-breather mask. So this one has got a, I can use it for other things. When you're using this, you need to be, you can see this, it has got a reservoir that is going to fill with what? Oxygen. Okay, so this has got a oxygen reservoir, and we connect oxygen there and connect oxygen into the cylinder or the wall oxygen, just like a normal Hudson mask we are connecting. What's the benefit? When patient is breathing in, they can get 100% oxygen because it is filled with the oxygen, and the CO2 will go through this side, and it has got a non reflexive valve as well, so the CO2 will go out, but some if don't need, they don't need to suck the air in from the atmosphere. So patient is going to get more oxygen with this. Yeah. And other one is Venturi mask. So probably I will just show you the oxygen is transmitted. Yeah. Yeah. So when you are looking at that, if you have that ABG in ICU, they will ask you what is oxygen percentage. So it is 1 liter if you are giving, it is 24. What is the atmospheric oxygen level is 21. So if you are giving 1 liter 24, you can see the rest of those things. So 1 to 4 liters only preferable for the people. Nasal prongs is yeah, we already covered that. Face mask, we already covered this. Yes, we done that. So the Venturi mask has got different color coded jets. So this jet, what will have, if you are using 24 one, it has got more holes, so it will mix with the air more. When it comes here, see, as you can see, the hole is becoming less and less. That means it is not mixing with air more. So purely oxygen is 60 liters, 60% of oxygen is going there. So if your patient needed more oxygen, you can go into this size, I mean these colors, yeah. And this one is high flow laser prong. As I told you, it is a laser prong. It is a big one, and it can give bit of flow also. Okay. Other nasal cannula can give only what? It can give only the oxygen, but it will give bit of flow also. Yeah. It will take long time to discuss all this flow, pressure, all those things. So we are just today, what we are seeing just the basic devices only, oxygen therapy. Yeah. If you want, we can go through that later. So with this, what is the benefit of this? With this, we can't humidify the patient oxygen. So with high flow nasal bronchs, we can humidify the oxygen. This device is called humidifier. So when we are breathing, we are humidifying the oxygen, isn't it? Yeah. How?
Yes.
Yeah. We got a respiratory system has got that humidification. So it is getting warm, plus the cilia is moving the things and it is taking out all the unwanted things, plus when it reach into our lungs, it is becoming 100% humidified because it has got enough temperature there. Yeah. When we are giving this, we are giving dry oxygen. Patient is getting dry oxygen. They are sick. Their cilia is not working good because it is all down. Maybe it is full. There is full of secretions, so it is not humidifying enough. Then what we need to do? We need to do extra humidification with this one. So do you know how the oxygen is transported? Any of you? Which form oxygen is transported from the company to here? Which
It's
form?
liquid.
Liquid, yes. So what's the benefit of doing that? Because if you have 5 liters of liquid oxygen, if you bring it here in the tank, and they can make 5,000 liters of gaseous oxygen. So that's a benefit. So they can easily transport that one from there to here, 5 liters and 5,000 liters. Okay, then what is the problem with that? When they are transporting that into liquid status, the temperature should be minus 120. They need to put it in an ice, more than ice is 0, but they need to have the minus 20 degrees centigrade. When they bring it over here and making that into the gaseous one, still they will make it maybe the temperature 10 degrees centigrade. So if you look at the wall oxygen, it is bit cold, yeah, not like atmospheric temperature. It is bit cold. That comes around 10 degrees centigrade. So if you are giving that to the patient, they can get what? They can get very cold and not humidified oxygen. That will develop what? Mucus plugs in the respiratory system. So they will have mucus plugs in the system, then you need to work hard to remove that. So always try to give warm and humidified oxygen. That's the benefit of humidification. So you can see the temperature, it is warming, and it has got coils in between, so that will give a bit of humidification and temperature. Yeah. So always try to encourage people to give humidified oxygen, but not always it is possible. Whenever it is possible, give that. High flow oxygen therapy English use part of both ward-based and critical care management or respiratory failure. I'm sure that you look after patients with high flow nasal bronchs. Could anyone say that what is the main complaints of patients when they are using this? Any complaints they have? This is a high flow nasal bronch. Or what should be careful with this? You can develop pressure injuries, and this is big one. So this is a small nasal cannula, but still it is big. Usually they say that it's heavy, yeah, and the warm air is pushing into their nose, and it is bit moist also. So the water may go inside. After sometimes they will start leaking. Yeah, they will say that, oh, I don't want this because it is making me sick. Yeah, but it is good for them. Instead of giving the dry oxygen, always try to give humidified oxygen. You can give this one. This is a high flow nasal bronch. You can have it. Yeah, this one we will this cannula we connect here, and patient is getting high flow nasal bronch, high flow therapy. Yeah. All right. Yeah, this is another device we are using. If you are going after the high flow nasal drops, patient is not coping well, what you will do, you will go into non-invasive ventilation. Non-invasive ventilation is what? Just giving some pressurized oxygen, that is, we are using a device called CPAP or BiPAP. Then we put this mask in their face. It has got a very sealed mask, and the pressurized oxygen tubing will be connected here, and patient will get some PEEP and pressure support. PEEP is what? Positive end expiratory pressure. At the end of the expiration, patient is the ventilator or the machine will leave some sort of pressure inside the lungs. So what is the benefit? If you are thinking about a balloon, it is sticking together. So when it is very hard to blow, in the beginning, we need to just start opening. Once they start opening, what is very easy to blow, isn't it? When it is sticking together, very hard. So that's what PEEP is doing. It is not letting the alveolar collapse or stick together. It will leave a little bit of pressure at the end of the expiration for helping with next breath. That is doing, that's what PEEP is doing. Okay? At the end of the expiration, there is positive and expiratory pressure. So this machine can give a bit of positive and expiratory pressure, PEEP, and pressure support. It is pushing pressurized oxygen to the patient's lungs, so the lungs can get a bit more oxygen and they can get enough tidal volume. Okay? Yeah. So you want to see this also?
We'll pass
Yeah.
it around.
Yeah. Okay. So before that, maybe Anna can show how to correct this one. What are the things we need to be mindful with that? So when you're connecting,
Connecting for me.
yeah, you can.
So usually it's connected already, right?
Yeah, the mask.
Yep, application,
Yeah,
you born.
it's a clean one. Yeah. Yeah, it's connected there. Yeah. Yeah, this way it is, and we are connecting the CPAP here. Are you comfortable? Hypoxic, CO2 is going. So, what I wanted to say, once you fitted this one, this is not leaking. You can go up and down, there is no problem. We can connect this one also. It's okay. Thank you for being a model for us. Eh? How to talk. Yeah. So that is very, patients will say, try to say something and they will do actions, but very hard to understand. So if they want to talk or if they want to drink, what you will do, you don't take the straps off. Don't do that, never. It's already fitted for her. What we can do, just take one side off. Yeah? See? Hi. Then put it back. If she's going to talk more, let me put it back. Yes. Leakage, yeah. So if it is leaking what? If it is leaking what? We can adjust the mask according to that, and we will know in the ventilator it will show leakage more than 60, more than 70. Then we need to adjust that. Maybe how we can just put it back. So, a bit more tighter, but don't take it out each time. It is very uncomfortable for the patient sometimes if they are claustrophobic. So if they are claustrophobic, what we need to do? Thank you. If they are claustrophobic, or if you are applying this one first time, what we need to do? You just go and put it and tie the strap. You don't do that. You just hold in this way and ask them to breathe normally. Okay, this is going to be like this, and we are going to put the straps on later. Okay, so you can hold the mask for maybe 2-3 minutes, talk to them. Once they are ready, what you can put the straps. And it has got it will rotate the side and everything.
Often is also very difficult in that as well, so if you need to do the cough assessment, they can have what they want to do. They can do the side strap, and you can open up what the strap is, and just cover that, no problem. Even if you're doing their bubble caps and everything like that as well.
Yeah. Okay, so that is CPAP and non-invasive ventilation is a big topic. Maybe around 2 hours we can talk about that, but we don't have time to do that, so we'll just go through CPAP bypass. CPAP is continuous positive airway pressure. It's bi-level positive airway pressure. CPAP is giving only the positive airway pressure, but BiPAP is giving inspiratory and expiratory pressure. So it is taking out a bit of carbon dioxide also. So if patient with CO2 retention, which mode would be the better one? BiPAP. Yeah. So bit rushing. If you don't get anything, you can ask me later. Patient positioning. So it's very important. Lung space. Yeah. So humidification we covered sort of. Yeah. In a normal inspired air, there will be enough humidity achieved. Yeah, patients with the tracheostomy, 100% we need to humidify the oxygen for the patient with tracheostomy. Why? Because we are bypassing the upper airway. Yeah? Yeah. So they won't get any humidification if you're giving oxygen directly to the trachea. Tracheostomy is what? Maybe the students. Oh, we are opening the trachea here, yeah, and put a tube there. So we are bypassing, because if they have any facial trauma and if they need a long-term intubation, because oral gas, endotracheal tube is oral tube, that is we can't keep more than 10 days, ideally. Then what they do, they put a hole here, that is called tracheostomy, and connected to the ventilator. If they are getting, after the ventilator is taken out, if you want to give any oxygen, you need to humidify the oxygen, because we are bypassing the upper airway. All right. Yeah. For the lungs voice, we need to humidify it. So these all things integrated. So the next class maybe can talk about intubated patient, mechanical ventilation for NIV. If you want, we can go through that, the modes and everything. Okay. All right, in ICU, there are many things. HME is a heat and moist exchange. That's a filter, yeah? Heat and moist exchange, that's a filter, that's doing the same thing. Because if the other humidifier is not available, we can use the filter, that's a HME filter. Hot water humidifier and nebulizer, yeah, those things we are using there. Okay, I think that's it, but before we go, I just want to introduce this. This is a very good piece of equipment which we can use many times. So, you know what it is? Yeah? Yeah, bag valve mask. Bag valve mask, we can talk about that at least half an hour, because many things we need to talk, learn about this. But we won't do that. I just wanted to tell you a few things. This is the oxygen connection that goes to the oxygen outlet, and 100%, 50 liters, we put it up. Once we do that, this bag will get inflated with oxygen, connect to the patient, yeah, then back. There is a technique for that, with 2% technique, 1% technique, there are different techniques, but the most important thing you need to be mindful that it should give a good seal. People with beard or without teeth, proper teeth, it's may not give much seal, but if you are not getting much seal, don't press hard, you just position it into the side, yeah? So bag wall ventilation, when you are using that, if there is a cardiac arrest, okay? If there is cardiac arrest and patient cannot breathe themselves, if you are giving Hudson mask, nasal box or anything, it will work? No. That's the main thing you need to be mindful. Patient needs to be conscious enough to use these devices. They should be able to breathe by themselves. If they can't breathe by themselves, we can use this one before intubating the patient. Before putting an endotracheal tube in their throat and bag the patient, we can use this as an emergency equipment. You just put in the face and press this. Yeah. So this can contain up to 1.6 liters of oleum. How much we need? If this 100 kilogram person, we may need the tidal volume of 500 or 700. Yeah, 5 to 6, 7 liters per kg. But it has no need to push all the way. If you do that, what will happen? Patient will get barotrauma. Okay. So just enough. Maybe one hand should be enough. Yeah. Yeah. And you can use oropharyngeal airway and nasopharyngeal airway for this. How do you measure the nasopharyngeal airway? From the tip of the nostril to the tragus of the ear. If you have a oropharyngeal airway, how do you measure? From the incisor to the angle of the jaw. Okay. So you can use that one of those. The techniques are there. There is no time to talk about those things. This you can have a look, and otherwise I think we have covered all the oxygen devices and mechanical ventilator and NIV. You can talk later. Yeah. Yes, you can try. It's a clean one. Yeah. When you are using that, you need to have, that's, yes, yeah, seal it properly. So you should have a EC. E is this, C is this. So EC. Then, yeah, EC material. Then bag. If I'm bagging, you will get some drugs because I see it nicely. So I don't want to do that. So just do this. Yeah. So always remember that EC method. And if you have two people, you can hold on this. Yeah, you can hold this way, and it's giving. And if somebody is asking for a PEEP valve, positive end expiratory pressure, they can put the valve there. Otherwise, you can use this one. Many things we need to cover. It was rushing in service, but hope you got something from this. And if you want to ask anything, you can ask me. Otherwise, thank you very much.
Thanks so much.
We'll talk mechanical ventilator no later.
Thank you. Thank you.
Thank you. Thank you.